Welcome back. And you might recall when we left off with a puzzle. Archon Fung suggests that democracy is an important predictor of public health response during pandemics. But what we know is that even among developed democracies, there's a lot of variation. Some countries do better than expected, those sort of below the line based on our sort of observations of various health variables. And some developed democracies do worse than expected based on those conditions. So what's going on here that maybe democracy alone can't explain? And one way of thinking about this is that electoral democracy affects something important, right? It affects the incentives public officials have to be responsive to public health demands, right? The idea being that if you're not responsive, perhaps you will not have that job any longer, you'll be voted out of office. But having public officials that are responsive might not be enough to deal with the outbreak of an infectious disease. In addition to having an incentive to do something, they might have to have the ability to do it. And one way we can think about the ability to respond to infectious disease is state capacity. Does the government have the ability, the resources, right, the raw materials, bricks and mortar for public health departments? Does it have the skills, right, the expertise of people on the ground who know what they're doing when it comes to sanitation work? And does it have the ability to coordinate resources getting from point A to point B, right? Can we send PPE and ventilators to a state where they're needed very quickly? Right? All of those things describe state capacity, right? And not all governments, not even all developed democracies, have the same kinds of state capacity. So in the 1930s, the United States was a democracy, though democracy varied even more extensively than it does today across different states. But the thing that really varied that mattered on some public health issues was the capacity to do sanitation work. One important example of this is malaria. Right? In rural parts of America, there were huge outbreaks of malaria in the 1930s that affected people in sort of tenant farm type communities. And for a very long time, the thinking about why malarial mortality disappeared over time was that people moved out of those areas and there were other kinds of farming that emerged. But what we know now is that if you go back and look at the counties where malarial mortality was the highest in the 1930s, and then you compare those to the counties where it was lower, the one thing that really matters is, did they have Works Progress Administration drainage projects? In other words, did their local, state, and federal government come together and drain swamps where these mosquitoes that carry malaria would breed? Right? So could the government actually drain those swamps and reduce the spread of malaria that way? And so what we can see is that the amount of drainage work in a given county and the cumulative drainage in preceding years significantly improves rates of malarial mortality. They go down pretty significantly when that state capacity exists. Right? There's one clear piece of evidence that it's not just about what elected officials have the incentives to do, it's what can government do with the power and capacity that it has. Now, one thing to note about public health capacity in the United States in recent years is that it peaked in about 2008, both in sort of per capita dollar terms, that's the black line here, and as a percentage of national health expenditures. But since about 2008, it's declined, and you can even look back to the 1990s and sort of declined even more if you look at it in those terms. And one thing that we can see is that, especially after the Great Recession, local and state governments shed a lot of their budgets for epidemiologists and other health workers, meaning that when something like COVID-19 came along, a lot of that coordination work that we might have needed them to do, they weren't necessarily equipped or in place to do. wasn't enough emergency equipment, not enough N95 masks or PPE. Additionally, we have something called the National Pharmaceutical Stockpile, but it's never necessarily had the reserves necessary to manage a crisis the scale of COVID-19. So while the United States is often thought of as a sort of high state capacity country, there are some limits to state capacity here that have really affected pandemic response. So when we look internationally, we see a similar pattern. So there's a measure of something called government effectiveness, which takes state capacity into account. And we can look at the relationship between this measure and the number of COVID-19 deaths per million. And the chart here that you'll see is a plot of correlation coefficients. So looking at the relationship statistically between ratings of government effectiveness and the number of COVID-19 deaths per million in a particular country. And it looks at it over time, right, over the first 250, say, days of the pandemic. And what we see is that as the pandemic has gone on, government effectiveness is increasingly negatively correlated with the number of COVID-19 deaths per million. As your government gets more capacity, it's more effective, you have fewer deaths per million. And that's true, very interestingly, even when you compare for the age of the population, which is a huge predictor of COVID-19 deaths, disease prevalence, life expectancy, health spending, and data quality. In other words, government effectiveness, state capacity is doing something meaningful here when it comes to reducing the spread of COVID-19. So it's a really interesting finding, and it's something that's different than what Fung is talking about with democracy. It's not just about the incentives, it's also about the ability to control the spread of these diseases. Now, state capacity and electoral democracy aren't the only sort of features of institutions that matter. Because beyond shaping elected officials' incentives to respond, institutions can also shape the way that officials make decisions about pandemic response. One example of this we can see is that in the United States, we have a federal system. A lot of the power around pandemic management rests in the hands of governors. And so early on in the pandemic, governors had these multi-state pacts to coordinate the stay-at-home orders across states. So there would be similar kinds of rules in different states. That lasted for a time, but these were informal pacts. There was nothing binding those governors together, nothing formally to keep them at the table, coordinating with one another. And so as politics in different states pulled those governors in different directions, they started doing different things. And these pacts gradually started to fall apart in different regions. So there are a couple different kinds of institutions that can really shape the way the governments respond to something like a pandemic. And one of them that we're going to talk about extensively is that of veto points. So veto points are institutions, the existence of multiple institutions that have to sign off before national decisions are made. So if you are familiar with the Schoolhouse Rock cartoon, I'm Just a Bill on Capitol Hill, you have multiple branches of government and they torture the poor bill and make it very, very hard for the bill to become law. That is a system in which there are multiple veto points. Because we have a presidential system with multiple branches of government and two chambers of Congress, it can be very difficult to make decisions, even when there might be majority support for them. By contrast, in parliamentary systems, there's only one chamber typically that matters, and there's no independent executive, so decisions, especially in times of emergency, can be made rather quickly. So veto points can make decision-making slow during a crisis, and there's a really good example of this in the United States, which is that in the early days of the pandemic, it effectively took a huge hit to the stock market to get Congress and the executive branch together to pass some major COVID-19 relief legislation. Since early spring, there's been no significant changes to that legislation, even as facts have changed on the ground, not because people in Congress and the executive branch don't want to do anything necessarily, but bargaining in this condition where there are multiple veto points, especially when there are conditions of ideological polarization that pull parties apart from one another. They can make those veto points very, very powerful in slowing down decision making. And so one thing that we see is that countries that have a larger number of veto players also tend to have higher rates of COVID-19 death per million, again, even when you control for a lot of other factors. So this is the same sort of cross-national results, and these are the correlation coefficients between the number of veto players, the number of institutions that have to sign off before national decisions are made, and the number of deaths per million, and looks at it over time. And you can see there's a pretty consistent positive relationship between more veto points and a higher number of deaths per million. So having multiple checks and balances can be good for a variety of reasons, but it can also slow down important decision making. And we've seen this, of course, in the case of the United States. By contrast, there are other institutions that can make decision making a little bit easier, or can turn up the heat on elected officials, much like elections can, even between elections during something like a pandemic. And one of these that's really important is an independent media. An independent media acts in a similar way to elections by keeping politicians attuned to sort of popular preferences or demands. The media can be important because governments get credit from media outlets for responding to crises. They have greater incentives to do so, right? They get a positive sort of reward, or a D in our little collective action equation for doing so. So it can act as an accountability mechanism that forces faster action when a crisis emerges. And indeed, when you look at indices of media independence, they tend to be negatively correlated with COVID-19 mortality over time. The more free and fair media you have, the more sort of independent checks on government in the form of independent media, you get lower mortality rates. In part because media is an important watchdog in actually spreading information about sites of outbreaks. And we've seen this in a number of cases at nursing homes, meat processing plants in the United States as well. So media can be one important, again, not necessarily a health specific institution, right? Not the same as a public health service providing capacity, but as an institution that provides some independent check on a government's response to a pandemic. By contrast, and this is going to be a little bit similar to when we talk about veto points, federalism can have an effect on the response of governments to pandemics. And when I say federalism, what I mean is the extent to which power in a country is decentralized. And in the United States, we have a great example of this, which is that only state and local governments can impose stay-at-home orders or mask orders. And while this can be good for a variety of reasons, because the pandemic may play out differently in different states, it can also create coordination failures that mean that it's harder to monitor, manage, and control the outbreak. One example of this is that early on in the pandemic, you might recall, states have very, very different strategies. Some took a very strict lockdown approach, others did not. And so there were conflicts between states with checkpoints set up at the state border that targeted out-of-state residents. And there was a lot of conflict over this, but this is one reason why federalism can make it harder to coordinate on those public health measures. And even in the early days of the pandemic, not all states were measuring mortality rates or monitoring them in the same way. This is a problem that's largely been solved for the most part in the United States, but there are still federal countries where it is a problem. And I'll just point to one of them here, which is India. And this is some research that looks at the quality of COVID data in different states in India. And the scale goes from low is in the red here, high is green. And really what this is looking at is, do different states report on things like the number of hospitalizations, the number of cases, the number of tests, the number of deaths, things that are really important when you're thinking about managing a pandemic. And there's a lot of variation, even within one country. And there are states like Kerala in the south with a lot of data and very high quality data. And then there are states like Uttar Pradesh and Bihar where data is of a lot poor quality. And so what we can see is that in a federal system, it can be difficult to coordinate even the production of knowledge. What do we know about a pandemic can vary significantly from place to place, and that can make it a little bit more difficult to coordinate the management of the pandemic at a national level. Now, there is something that I want to note, and you saw this in the reading by Scott Greer and his co-authors this week. Not all federal systems are the same, and especially when it comes to public health. Federal systems work somewhat differently in different places. So, for example, during COVID-19, Switzerland, which has usually a very decentralized system of public health in Swiss cantons, centralized authority over physical distancing requirements. So temporarily moved that authority to the national government, which is very, very interesting for a very decentralized federation like Switzerland. By contrast, there are countries like Belgium, Canada, and Germany left social distancing requirements, physical distancing requirements in the hands of regional governments. Now, that's not necessarily a bad thing. However, in Canada, it has led to huge divergence in the rates of infection and mortality. Quebec, because it has taken a very different approach to managing the pandemic, has become a huge hotspot and has helped to keep Canada's rates of infection and mortality very high relative to other similar countries, and even relative to a lot of other provinces in Canada. And so because those provinces really had control over the management of the pandemic, there became a lot of variation between places and a lot of difficulties when it came to coordination. So the point here is that it's not just the existence of elections that matter. As political institutions go, we have to look at state capacity and how it affects government's ability to actually provide for public health. But we also have to look at the institutions like veto points, federalism, and the independent media, because they can also affect the way that decisions are made. So it's not just electoral democracy that matters. When we come back, we're going to talk about how it's not actually just formal institutions that matter either. There's something going on at the level of culture, sometimes language, but also the relationships that people develop with one another that matters as well. So when we come back, we'll do that. This is the end of part 2. You can go ahead and take a break, complete quiz questions 2 through 4, and then I will see you back for the final part of the lecture.